Since 2015, Pop Health Podcast has brought to you some of the best minds in healthcare, including leaders from government, not-for-profit, and investor-backed powerhouses, as they share successes, failures, and how our audience can move forward in today's constantly evolving healthcare world. Thank you for joining us for today's episode presented by 24 Hour Home Care.
Hello, everyone, and welcome to another episode of Pop Health Podcast. I'm Gavin Ward, host of Pop Health Podcast. In today's episode, I had the opportunity to sit down with John Ohanian, who serves as the Chief Data Officer for California Health and Human Services, and also is the Director for the Center for Data Insights and Innovation. In today's episode, we really focus on what's known as the Data Exchange Framework, which is an initiative here in California that ultimately asks the medical world and the social services world to come together and share information with the purpose of serving individuals and best coordinating care for those individuals. Now, some of you may be familiar with the Data Exchange Framework or realize, oh shoot, I actually need to be a part of that. And we hope today's information from John is helpful for you. And also you have a little bit of fun hearing about John's background. And you might hear some fun facts about summer camp and working in the backyard. We hope you enjoyed today's episode. Feel free to check out other episodes of Pop Health Podcast by visiting us at pophealthpodcast.com, checking us out on our YouTube channel, or visiting us wherever you listen to your podcasts. Thanks, everybody. Enjoy today's episode. John, thanks so much for joining the show today.
Thank you. Thanks for having me on. Really excited.
Yeah, likewise. Absolutely. And folks, before we got started in today's episode, I learned a little bit about John's work in his backyard. So a quick fun fact, and I'm going to ask you, you can't use this one though, but I'm going to put one out there for you, John. John's quite handy. While he doesn't do all the handiwork, he's got some experience with Tough Shed and backyard projects. So he's actually going to be helping me after today's episode of giving me some ideas. So that was a great first impression I had of you, John, in today's prep for the show. So I just want to thank you. But that does not count as your fun fact when we kick off our episode. So I do want to ask if you can share with the audience something about yourself that might be a fun fact, hobby, something like that.
Yeah. So but just by virtue of being bored one day about 10 years ago, I got a little ranch in California in San Diego, outside San Diego, and it has been a major tinkering project. And I've kind of been learning as I go, from learning about septic systems and trying to have a self-sustaining unit on the property, and then experimenting a little bit as I've moved up to Northern California. So I definitely like tinkering. I like learning. It's amazing what's out there on YouTube, and kind of nice to have your mind on different things that maybe you deal with during the day. So
that is awesome. And what's funny, John and I were talking before recording about the process of the episode and how it goes out to the public in a few weeks from the recording. And actually the editor, John, you and him share some similarities. He also has a property out in the San Diego area, kind of in the middle of nowhere, and he's tinkering.
Oh, yeah.
So he's also done the backyard thing. So now that we're talking, that's pretty cool. So John, before we get into your work with California HHS and data, which is the topic of today's conversation, can you tell us a little bit about your background and ultimately how you fell into where you are today?
Yeah, well, growing up, I thought I was going to be a summer camp director for the rest of my life, and really enjoyed that as a kid. But I ended up, because I was good at numbers in college and had to pick a major, I picked accounting and went, at that time, Big Six, now Big Four out of college. And after a couple of years, definitely felt like a square peg in a round hole in terms of I knew what I liked, I knew what I didn't, and was fortunate enough to land in the nonprofit space in San Diego. And through that work, worked with a number of nonprofit organizations, worked in a number of startup, both for-profit and nonprofit, and learned a lot about organizational setup using my finance background. But I actually think I used my camp background a lot more in leadership and in terms of trying to build culture, and not realizing I was building culture, but just I think, whether growing up or whatnot, just trying to treat people as you want to be treated, and being excited about the projects I was working on. We ended up, I feel like, moving several movements that ended up kind of by circumstance. I'm sitting in a seat at the state now, looking back at those projects and seeing how it really helps me do my work today.
That is awesome. So summer camp, I'm curious because I was a summer camp kid and worked in my college summers at a summer camp. So were you doing summer camp like down in the San Diego area, like the
Yeah, so
mountain?
I'm a native New Yorker. So
Oh, okay.
my camp was upstate New York in the Catskills, but we lived in California for a lot of my youth. So I was going back and forth for the summer. I was basically gone the day after school ended and came back to California the day before school started.
Wow, man. Yeah, that sounds like you probably had a lot of adventures and maybe that was a catalyst for some of the skills you have today in the backyard. So that's great. So tell us about, well, actually, I want to backtrack a little bit. So you
Yeah.
mentioned the big four and big six. So some folks may not know what that means in the accounting world. And today's episode is not about accounting, but it is about data. So
Yeah.
can you tell us the big four, what does that mean?
So they're public accounting firms, the KPMGs, the now Accenture and Deloitte's and of the world. So I was in accounting. I was in audit, basically validating folks' numbers. And if you just hear the word audit, it probably sounds like it actually is. And so at the time, I actually finagled a little bit with computers. I had a Commodore 64 and then an Apple, and I actually just was basically like trying to program. I just enjoyed it. I enjoyed all the applications, but it was a time when a lot of those big firms were still paper based.
Okay.
Showing my age a little bit on this, but it was the first time that computers were being used in the workplace in audit. And so fortunately, that was something that I could leverage. While I might not have enjoyed the audit work, I really enjoyed the bringing computers into the workspace and wanted to move into consulting. And I think kind of ended up there, but consulting a lot more in the nonprofit space and social service space.
Awesome. Okay, cool. So that makes a lot of sense. So today, looking at my notes, I can't memorize your title, but you're the Chief Data Officer for
Yeah.
California Health and Human Services, and also the Director for the Center for Data Insights and Innovation. That is a quite a long title, but clearly shows you know what you're doing. So I want to see if you can give us an overview of what the
Sure.
center is.
Sure. So I was fortunate enough. It's now been 4 years. It was actually Valentine's Day 2020 when I was reintroduced to Marco Meach, who is our undersecretary at California Health Human Service Agency. Actually, just left as of last week. So today's like my first day on my own. I feel like we just had a team meeting and just celebrated his leadership and a lot of the initiatives. This center was really a brainchild of him, some other leadership, including our secretary, Dr. Galley, who had this idea of this data community that continues to grow. We're seeing it in every business. We're seeing it in every industry. Everyone's talking about data. In California Health Human Services, we had a history of these massive departments and these enormous data efforts happening individually, and more the data communities from our 14 departments. Just to give you scale of Health Human Service Agency, a couple $100 billion agency with 45,000 employees, just our agency, and that's 14 departments. So from CalFresh, which is California's SNAP programs, nutritional assistance programs, to your Medi-Cal programs, all that sits within California Health Human Service Agency. And so with all these data professionals, we're very data rich. We knew that. And so we wanted to formalize a little bit more of our data practices agency-wide. We have a mission that we're not about data, we're about people. How do you serve a person? And we'll kind of get into this a little later, so tell me if I'm going off track. But it's really this approach of how do we get folks to see it as an important critical asset, both from program standpoints and socialize it throughout the agency. And so this center was an idea to bring those folks together and formalize it under an organization. So I can talk more about it, but that's really what the center is about, is how do we kind of take these ideas and innovate and incubate to allow this to happen.
Got it. So you mentioned the 14 different departments within California HHS, and you said, did I hear correctly, 45,000 employees?
Correct.
Woo, okay. So, but it's not just for your department. Like there's a flow down, right, to all of California. So besides California HHS and the 14 departments, who's involved in California?
Sure. So state doesn't do it alone. We're a big partner of the federal government, and so federal programs get administered throughout the state. Different self-sufficiency programs, assistance programs of various natures that happen. The state is really looking at how do we coalesce and be as strategic as possible, because if you think about it, the system is set up to fund programs, but we're trying to serve an individual. And so it's really, how do we take these collective programs and break them out of silos? And that we've done a really good job with a number of these initiatives agency-wide. So let's focus agency-wide on folks that have developmental disabilities. Let's focus on our aging community and have a master plan for aging. So each one of these encompass not only state programs, local nonprofit organizations that serve programs, faith-based organizations, coalitions, kind of like everyone's involved in helping an individual, but how do we make sure that it's done in a strategic way, in an organized fashion? And so those are the types of initiatives that at an agency level happen under the secretary. Okay. And then me being the chief data officer, the goal is, how do we ensure that the data is flowing, the data is protected, there's good governance, starting from basic governance, but that it's able to deliver at the point of care a better service, and we're able to evaluate that data to look at where we could be making changes in our programs to improve program delivery. And so if you look at a chief data officer at any organization, every one of them looks a little different, is what I'm learning.
Yeah.
And priorities are different. And so I'm trying to take a programmatic way to support our leadership in ensuring that they have the best, latest, greatest tools, so that technology is not a barrier, governance isn't an issue. They're able to actually use the data that they need at the point of care.
Got it. Okay. So when I first, I don't know, I don't know if, forgive me for not recalling, but I've heard either you or one of your colleagues speak before, and I was a little bit intimidated by this data exchange framework.
Sure.
My day job is working for an entity that historically had not been labeled healthcare, but we provide in-home care, right? That's non-medical. And I thought, oh man, we're going to be required, and I was off here, but I thought, oh, we're going to be required to go on this new technology platform, and it's going to be a requirement from the state. And I misunderstood.
Mm-hmm.
So the data exchange framework is not everybody signs up and is a part on this one platform, correct?
So let's talk about the data exchange framework. So we kind of spoke about CDII in the center that I lead in terms of the team of helping these types of initiatives that will advance data sharing. Okay. And so you brought up the data exchange framework. So just quick background. The data exchange framework was created by legislation. So the governor signed it in 2021, actually around the time that CDII launched. So it was like two startups in one. Really, really an interesting opportunity. And so the legislation established the state's first ever requirement to securely share between health and social organizations. So your point exactly. There is information sharing that's already happening in the health exchange community. In fact, ONC just celebrated their 20th anniversary. And so we now, Office of the National Coordinator, sorry, I saw the look.
Thank
So
you.
the Office of the National Coordinator that sets data standards and data sharing standards across the country just celebrated 20 years. So we knew as a state, health exchange was happening, not everywhere and always. We know that it continues to evolve, but there's a substantial health information exchange network within California. What we knew we needed to do is allow social service information to exchange. And to do that, we needed a framework of sharing that both supported health, which already was there, but maybe shored up some areas where health exchange wanted to go. We can talk about that. But really it was to then bring on social service organization. So the reason why I'll kind of stop with this is it's not technology. We didn't need to build technology. It's rules of the road, guiding principles of sharing, how to share, when to share, and things of that nature.
Got it. Okay. So who is like obligated under this framework to participate?
Sure. So there's been, I'll just share what's been interesting about it is while there are health exchanges around the country, this is the first legislation of this type However, we're seeing other states now adopt it. So it's kind of like this beginning trend of we wanted folks to share, but we knew that if we didn't insert a kind of a requirement, it wasn't going to happen to everyone always. Certain providers would, but other communities, disparities, we always focus on equity. Looking at it, we understand where we needed to raise that. So that's that. So think about all your major hospital systems. They need a sign. Health plans need to be on board with this. Providers, and in providers, we have staging. So it was larger medical providers at first, while acute care, and then moving on, because to your point, smaller providers, social service organizations, a lot of them lack the ability, frankly, not the willingness, but the ability in terms of technology, whatnot, to get there. Yeah. So during this process, we actually just completed a $50 million grant round that we're giving out to organizations. And I will say that it's been really interesting because while the data exchange framework is a law, from enforcement, we haven't been able to say if you didn't sign, or you have to sign this agreement by this date. It was all by the willing. And I'm proud to say that we're at over 50% of all organizations that were required to sign have already signed on board. So we now have critical mass of over 6,000 organizations. And when Sutter Health or Kaiser are 1 out of 6,000 of these, you can tell the enormous scope. So not only do we have a network, we have a lot going for us to now stage. Now let's begin doing exchange in ways that we haven't.
Got it. So what's an example of what is exchanged? So and why it's exchanged? Can you give us an example?
Sure. Well, everything we should ground exchange in consent. That nothing gets shared without someone's permission to share. So I take myself as an individual. When I was caring for my mom, and I would go into a doctor's office and they would say, fill out all these forms. So if I'm an individual and I say, you know what, this is my doctor, I want them to have everything. Or you know what, I want them to have everything but this. A person should be able to click, click, click. In the office, they pull up an iPad, and then their information is then shared with the provider. Same thing with provider to providers. If I'm a doctor and I need to speak to, there are certain practices that are already in place. Again, like I said, health exchange has been happening. There's rules of the road and guiding. With social service information, let's talk about that. One of the critical issues we have in California is our homelessness. Our counts, our care. We have programs that are really trying to target and improve. And what happens with that population, I experienced it personally in San Diego, is they might move to another community. They might be out of a neighborhood. And so when they get possibly picked up because they need assistance, they are taken to the emergency room. Wouldn't it be great if that emergency room were able to identify this individual was at the shelter 3 days ago and is already have a care plan in place and really just needs those types of things, you can tell, are such a churn on our system and are easily eliminated by it can be very basic information. It could just be an alert that says, call this care manager. It can be alert to ask the individual about that visit and, hey, can you consent for us? Lots of, it depends on, because I always err it on, we want to have the capabilities, but we want to leave it up to folks to be in control of their information.
Yeah, that's a really good point. And something that I've learned over the last couple of years is that word consent. That even though this is a requirement for providers, it's ultimately a decision by the consumer, member, however you want to say it. So that's really cool. So you got all these providers, they're signing up. You mentioned grants, like a $50 million grant to help folks with this. What are some of the barriers, besides obviously money is one, that are preventing folks from joining and participating in the data exchange framework?
Sure. So I think one of the barriers is, I think, time. I think that folks are very busy with COVID and, the healthcare community. You hear it, there's a strain on our system. And I think folks have a lot that they're dealing with, a lot of new things that they're having to deal with. And so with data exchange framework, it's really us getting out there as best as we can to educate folks. We did a big education initiative over the last 2 years to get to folks and help them onboard. So like right now, if someone said, what do I do? Right now, all they have to do is go to our website. They can fill in a request. They can request a meeting. They can download our toolkit, and step by step, we walk them through what it means and what they need to do. In practical means, if I'm an individual provider, what we've been able to do is partner with 9 health information organizations that exist throughout California. Some of these are local health information exchanges. Some of them are statewide providers of exchange. And we've given them a designation from the state. So now they're QHIOs, Qualified Health Information Organizations. So picture these 9 spread across the state providing a network. And so if I'm a local provider, if I go sign up with that QHIO, it begins the journey of being able to have exchange. Some folks need to have their own electronic health record. Other ways they can, with the cloud, there's amazing things that folks can do with instances and things of that nature. And so what we've really tried to do is stand out of what technology is picked and just ensure that there's a good framework of an infrastructure to exist for folks to share.
Awesome. So I know you probably can't say who your favorite is, but are you able to pick a community? You mentioned like San Diego. I know you're also, you spend time down there, but also your home base is Northern California. Are you able to give an example of a community that you're seeing some good success, some good momentum?
Yeah. I would say both in our state, but it's fascinating what's happening outside of our state. Okay. California is large. And so when we compare ourselves to most states where, some of our counties are the size of most states. And so we continue to feel like we're a little unique in that effect. But in my work, when I worked at the 211 in San Diego, and then obviously with our community information exchange, I feel like we've seen great success. And I think one of the greatest successes is what we're seeing at the state level as well is we would convene groups of folks in a room once a month when we were doing our work, and they probably continue this, just having folks shake hands, see each other across the table, all dealing with the same issue, if you will, right? In terms of we're all working on it together. We're having the same effect with our 9 QHIOs, because while these organizations, could possibly look at each other as competitors, right, in the space, or what's going to happen, because there's a lot of movement at a national level and the space is evolving very quickly. I think what I heard from one of the folks that had been in the space for about 20 years was that he had never seen this level of collaboration. And I think that's what we're looking for, because when you have that collaboration, we have that group meeting weekly, those 9, and they bring up issues and you're getting to it. And I talked about it a couple of weeks ago at a different talk, is the balancing of, we have to have our short-term goals that we can get through to have progress, but we also need to have an eye to long-term. And when I talk long-term at the state, sometimes that's 5 or 10 years, but we have to be willing to do both, but not get stuck into one outcome. And I think that's that group starting to solve, like, we're now at this new age. Maybe we had to pull some people to the table, but now we're here and a dynamic effect happens. And so now we have trust so that maybe they can look and see, what is that solution that we should be in place 5 years from now? It shouldn't look like we're doing right now. And lots of things, from ADTs to provider directories, right? Consent registries, all these things that need to happen. We're looking at them in the vantage point of, we have 20 years, so we think we know what we need to do. I'm trying to get them to pull from other industries outside of healthcare, like finance and retail, to say, how do we bring those learnings into the space to come up with something that might be simpler, might be less costly, and things like that.
That makes sense. I mean, you mentioned finance, and you have accounting background, so that makes sense that you would know to look there. Yeah. You mentioned ADT. I have ADT security, but I don't think that's what.
Sorry about that. So in the hospital world, there was something known as admissions, discharge, and transfers, and so that was really to keep track of patients within a hospital. However, now that you're thinking, right, some of these things came up before we thought of the future. Well, now we have hospitals talking to other hospitals talking to plans and providers. And so that desire to have notifications and alerts, like we just talked about with that individual in the emergency department, to have an alerting system that hits and pings anyone that might be connected to that individual, because in the exchange, right, that individual is identified. and folks who are their providers get to register so that when alerts happen, they're notified. Same thing here. If you travel to Northern California because you want to come and visit me, but you get admitted to the hospital here, how is your primary provider being notified that you've been hospitalized? Things of that nature. Again, this happens in some communities. It happens in some settings, certain vendors, certain providers. What we're trying to do is make sure that no one's left behind, and we can scale that to all facets of 40 plus million in our state.
Awesome. So you mentioned 50% plus providers have gotten there. So this is a very long project. One of the things I like to ask folks is, hey, 5 years from now, let's say 2030, for example, will this be done by 2030? Because this is a lot. Or what do you see in 2030?
There's a presentation that I think is given all around the country where you might have even seen the picture. When we talk about taking care of a person, there's the person in the middle, and then you have all the services around the person that you're trying to connect.
Yes.
And I really hate that visual because it's really taken me a long time to realize it's not that easy. And I'm not someone who likes to be wrong. And I always think that there's a simpler solution. But healthcare is so complex. Privacy is such a touchy subject. Now you lay on security, and don't even get me mentioned, right? Then we're going to say, are we going to mention AI once in this call? Because, and then it's these building blocks for, in folks' minds, possible disaster.
Yep.
But it's such an incredible opportunity. And so you're talking to someone who gave for 2 grandparents and 2 parents. And I'm not saying that I have empathy or understanding for anyone who's dealing with right? Like folks deal with that. That's every day. Yeah. And I had a lot of resources to my advantage, right? I'm in almost the healthcare space. There's a phone call away but what I experienced in San Diego dealing with a lot of folks that we dealt with, they didn't have those support systems. We were their only support system. So I feel like it needs to be the number one priority. And so in 5 years, we have transformational things happening. But I don't know if the question is, are we going to get something done in 5 years? Absolutely. Are we going to be frustrated with we're not far enough in 5 years? Absolutely.
Hi, man, you got some candor there. There's sometimes we get some wishful thinking answers, but I'm sure we'll have progress, like you said.
And we've seen it. And I think we've seen it. Like, in California in what I said, 2021. So in 3 years, we now have a statewide network of exchange. We now have a data sharing agreement that's been signed by over 6,000 entities. One agreement agreed upon by 6,000 entities. We have 12 policies and procedures, a dozen of them that talk about, we've all agreed on what's real time, what constitutes a breach, what's the notice of alert, all those things that require before you can sit down and actually do the work. And so in the days that I get frustrated, my former undersecretary would tell me, do you realize how far we've come? Because he's seen it at a federal level and at a state. And I will say, even our federal partners are looking at California saying, you've been able to advance and continue to advance. We're going to be watching it. So when we talk about social service exchange, there's not a national standard right now for social service exchange. So we're creating it, right? We're working together, but we don't want to do it in a vacuum just in California. So it's like, how do we do it with our nationals? So together we've rolled that out. Same with consent. There's not a consent standard. There's consenting happening, but we're not happening at scale for social service exchange. And so to your point, I think what we're going to see is a huge surge of growth in this area over the next 5 years in terms of it's going to be talked about everywhere.
Yeah, that's good. So what's going to get us to the finish line? So there seems like there's a lot of opting in right now, right? 50% of folks have participated, which is great progress, but we're not at 100%. Is there going to be a point where there is not incentives, but actually discipline for the folks who don't do this?
Yeah, I think that you're going to get there. And I think part of it is almost like when you leave it to the community, it happens faster. Because if I'm a provider and I go to try to connect, or if I'm a patient and my provider hasn't signed on, the question is, well, why not? And so I think that I don't believe that's going to be the issue. I don't think sign on is the issue anymore. Now the issue is it's really become on us who've gone out there and gotten everyone to agree to actually deliver on helping advance the actual exchange of social service and information. Because once those health providers have that in their hands, and I'm sure you get a lot of health professionals, it's going to be a whole new world for them. It's going to be they're going to actually feel like this individual who I just got to only spend 15 minutes with, but I know they have food insecurity. I was able to direct a referral to them to go get assistance. That feels, and so I think it's that work that if we continue to show those use cases of examples that are just very basic, the rest of it will happen because everyone will want to be on the system. So I think that's where the incentives come from.
That makes sense. To be part of these QIOs or work with the QIOs in the 9 areas of California, is there like a cost for organizations to be abiding by the data exchange framework? Is there one-time costs? Like, how does this? I know you mentioned grants. So yeah, it's a one-time cost.
There's grants, but there are costs. The question is, how much of those costs are they already spending? Because a lot of them are already connected. Are they going to connect to they don't have to connect to our network. There are folks that can get into collaboratives within their own communities, and then that community collaborative could decide how that could work. But yeah, there's cost. And, I would say that if we could get, a look at federal grants and opportunities to bring them down, community-based organization grants. And again, back to the earlier point, if we can make this a priority that we really need this, I think that's how we were able to, get $50 million a few years ago. And hopefully we'll watch the budget, and as things go, maybe have an opportunity there as well. But I think at the federal level, this is a priority, and I'm seeing that. I guess what we're going to try to do is figure out how we can coalesce it on behalf. The greatest funding opportunity in a lot of ways is through our Medi-Cal program and those providers, because when you think about CAHHS and that will allow that support to happen, so folks can see a benefit to participating. So,
John, for folks, you mentioned CAHHS. So, folks in the CAHHS initiative, a lot of them are not-for-profits. They're small entities. They haven't been required to provide data, but they might be interested if it's going to be a requirement for them, or if they want to opt in voluntarily. How do they learn more about what's relevant for the work that they're doing?
Sure. So I'll make a shameless plug and have them go to our website. We'll get them connected to the data exchange framework, and obviously they can contact us for anything else. Our website is cdii.ca.gov.
Okay, great. And then there's instructions there or contact information for them to take the next steps, correct?
Yep. When they go to that site, the third button is data resources, and the data exchange framework is the second choice, and you'll get right to our site. And from there, you'll not only see everything about the data exchange framework where we are today, but if you wanted to see the very beginning meeting, because it's all public meetings that we have, folks can come and listen in. We meet quarterly with the advisory group, and those are public meetings. So you can hear, you can participate, you can give feedback. We really want folks to give us their feedback. That's how we're, making sure that this program is successful. So thank you for that.
Yeah, no problem. Thank you, John, for spending time with us today. As I mentioned, I've heard, forgive me for not recalling if it was you or someone else from your organization over the last couple of years. And I was always curious. And so when I had the opportunity to have you on today, I jumped at it and really appreciate you making the time. So, John, you're the Chief Data Officer for California Health and Human Services. You are the Director for the Center for Data Inisghts and Innovation. You are a handyman, a summer camp guy, and you've been a great guest. So I really appreciate you, John. That's my dad's name and also my son's middle name.
Wow, love it. Thanks, Gavin.
Yeah, really appreciate it today, John. Have a good one.
All right, take care.
Thanks, everyone, for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.